Good afternoon, everyone. My name is Paula Tanabe, and I'm a researcher at Duke University. I'm also an emergency department nurse for over 25 years. So it's really my privilege today to be able to deliver this dissemination module on vaso-occlusive episodes in the emergency department, where we talk about pain assessment, treatment, disposition, and referral. Before we start, I would like to make a couple acknowledgments here. This is a grant that was funded by the Agency for Healthcare Research and Quality. It's a dissemination and implementation grant where the focus is actually on disseminating the evidence-based guidelines for the treatment of sickle cell, in particular vaso-occlusive crisis. In developing this presentation and in partnership on the grant, we've worked very closely with Community Care North Carolina and the North Carolina Emergency Nurses Association. That their input has been very, very invaluable, as our goal is to actually disseminate the algorithm and resources to all emergency departments throughout the state of North Carolina. This will be available on the web, and of course, if we can disseminate it beyond North Carolina and South Carolina, because South Carolina is also a really important part of our project, that would be wonderful. What we hope to accomplish today with this talk is to do a little bit of an in-depth discussion on how we actually should be assessing pain for patients with vaso-occlusive episodes. The majority of the talk is going to focus on the actual evidence-based recommendations from NIH on how to treat VOE, and we will go through those in detail. And then finally, we're going to present some data on a project that we've had with CCNC since 2014, in which we've been able to identify and refer patients with sickle cell from the emergency department for follow-up unmet medical and social behavioral health needs. To date, we have referred over 800 patients, or made 800 referrals out of emergency departments throughout North Carolina. And finally, resources. So also as part of this project, we have developed resources based on the evidence-based guidelines to help providers be able to treat sickle cell. In particular, we've created a toolbox. The Sickle Cell, this is an app that you can get from the App Store, and at the end of the presentation we will give you the link to the app. But on the app is the algorithm for the treatment of VOE, as well as other algorithms to help guide primary care providers as well, and to how to take care of patients with sickle cell disease. So before we get started, there's a couple pre-test questions for you to ponder. This is a 26-year-old female coming to the emergency department with severe pain in the lower extremities. She has SS genotype and has been hospitalized 3 times in the last year for sickle cell crisis. So how would you assess their pain? And you can kind of see the answers here, and we'll come back to these at the end of the presentation. The second question is really about a correct dose. This is a 43-year-old male with sickle cell. He has 8/10 pain in the back. He weighs about 100 kilograms. And so we're asking, do you know what kind of dose, what drug and dose would be appropriate for this particular patient? And finally, this is a question about referral, and this is a 22-year-old African-American male for the 3rd time this week in your ER complaining of VOE pain 7/10. So you have treated his pain, and he is being discharged home. So at that discharge, what kind of education should he get? So as we kind of get started, this is a patient with sickle cell, and I certainly can't relate to it, but this is kind of a hopeless looking figure. And this is probably what patients feel like. This is what they tell us, is that they feel very hopeless, they're in a lot of pain, and it's a very difficult experience for them, first of all, to experience vaso-occlusive crisis pain, and then also to come to the emergency department. From our perspective, sickle cell is a challenging population for many reasons. One is they do have chronic pain in addition to acute pain. And oftentimes there is a perception that patients are addicted to opioids, which results in a disease stigma. And there's data to show that there is actually sickle cell disease stigma. Racism plays into it. And probably one of the biggest barriers that I see is the patients with frequent visits. who you see a lot. And we're going to talk a little bit more about that. And then finally, oftentimes providers, nurses, physicians, etc., and don't have as much education about sickle cell disease as they should have, and that results in a knowledge deficit. And patients themselves sometimes have knowledge deficits about their disease and are not the most educated. Most patients are very educated about their disease, but not all the time, and all of that contributes to barriers to care. So I mentioned the high user, and I've heard this quote before many years ago, and I really like it. If you have met one patient with sickle cell, you have met one patient with sickle cell. Just like patients with diabetes and heart failure, they are all very, very different. So we really cannot generalize one patient to another patient. And it's really easy to say that, and it's really hard to do sometimes. Especially, there are two buckets of patients that come to the ER. There's the patient that has a high number of ED visits and the one that doesn't. So let's talk about the high number. There are actually a lot of reasons in the literature for this that we actually know and understand. We believe that they have more social behavioral health challenges. We know that they are sicker. They often have worse anemia, worse kidney disease, and worse pain. We also know that there are many health system barriers to outpatient care, and that is another really important part of our grant, and that is to be able to deliver resources and evidence-based algorithms to primary care providers so that they can also help take care of patients with sickle cell. It's often difficult for patients with sickle cell to find a provider. If they're fortunate to be in North Carolina and have specialists, that's great. But for the rest of their care, it's often difficult to find primary care providers. So there are many, many barriers in the health system. And what that results in is that patients are often stigmatized and assumed to just be addicted. On the other side of this slide, what you see is the infrequent visits. And these are the majority of patients. So the minority of patients, there's maybe about 10% of patients have a very high number of visits, and about 90% do not. So they rarely come to the emergency department. When they do come, they don't have a good experience, so they often wait too long, and then it's difficult to control their pain. And unfortunately, they are victims of the same stigma that is received by patients with high number of ED visits. So that's just a little background. Let's talk about pain episodes. So they used to be called vaso-occlusive crises. Now they're called acute painful episodes or vaso-occlusive episodes. And it is the most common manifestation of sickle cell disease. So this occurs when the vaso-occlusion at the capillary level, basically what you see is that in the situation of deoxygenation, the cells change shapes, they start to form polymers, they get very sticky, and they basically occlude oxygen delivery to the tissues. And this results in a lot of severe, severe pain. We also know we have some data here in North Carolina. This is North Carolina data for 1 year, 2016. This is not published data yet. But we looked at all the Medicaid patients in North Carolina who were enrolled for 12 months but were not dual eligible. And that was about 1,600 patients. And the total charges per patient had a big variation, but about $7,700 per patient with a standard deviation of about 18,000. When you put all the charges for the 1,600 patients together, for 1 year it was about $12 million. And that included visits, all outpatient visits, PCPs, specialists, emergency department visits, hospitalizations, hydroxyurea, opioids, and transcranial Doppler screening. So it's also a population that is that does have some high cost associated with it, even though it is a rare disease. And finally, there are some resources that we're going to give you at the end, but this is a particular video on how to assess pain, and that's where we're going to move now. So we're going to move now into talking about assessment of pain. This is a nice video, I think, in that it role models what we kind of normally do and what we normally think from a nurse perspective, a physician perspective, and a patient perspective as well, and tries to set straight some of the myths that we often have such as if a patient is trying to distract themselves or they know they're a particular dose. So I think it's a short video. All the videos on that website are pretty short. So we're going to move now into the actual evidence-based guidelines. So we're going to talk about this is the cover of the National Heart, Lung, and Blood Report that contain all the guidelines on how to manage sickle cell. And in this document is a chapter on acute complications, and within that chapter is a section on vaso-occlusive crisis as well as other complications as well. So I understand that you can't see this on your screen right now, but we're going to dissect it in a couple other screens. What we have done in North Carolina in partnership with CCNC, with North Carolina ENA, and North Carolina College of Emergency Physicians, we have taken the 17 recommendations for the treatment of VOC, and we have put them into an algorithm form. And importantly, this algorithm was endorsed by the boards of directors for both North Carolina ENA and North Carolina College of Emergency Physicians. So your professional organizations in the state of North Carolina have endorsed these recommendations via this guideline. It actually says that up at top here. So in working with the two organizations, one thing that was important is the first thing to determine is this person having a vaso-occlusive crisis? If not, then treat that complaint. And it could be that they're having acute chest syndrome. It could be that they're having something else. And so I think while we always have to, and we do want to believe the patient when they tell us they're having a VOC, they're having one, they also may be having something else. And there may be situations where the ED provider has more information about a particular patient, and they actually know that it's not a VOC. But this talk is all about VOC. So we're going to say that they definitely have a VOC. And so for that patient, the next question is, do they have an individualized management plan? Which means individualized dosing. So is there a dose on record in your electronic medical record somewhere in your health system that says this particular patient should get morphine 10 milligrams every 20 minutes, or they should get morphine 20 milligrams? And so that's really important for your emergency department to know. And that is because that is the ideal recommendation. And I'm going to go into a little bit more talk about that as to why that is. If they don't, and then what we're also going to ask is this patient utilizing outpatient care? And this is kind of the red flag for a high-risk patient. Have they had more than 5 ED visits in the last 12 months? Do they not have an outpatient sickle cell provider? And so are they basically not getting outpatient care? Are there red flags in the state prescription monitoring program? Are they missing a lot of clinic appointments? And if this is the case, we're still going to follow the algorithm, but we're also going to refer for additional outpatient resources. This might be a patient that needs a case management plan. They may need a pain management clinic. They may need an outpatient provider. They may need some other kind of resource because they're probably in your department frequently and you're not able to give them everything that they need to be able to actually get their disease kind of under control, get their care management under control. And if that's not the case, and then we still come back to it, patients are assigned a triage level, ESI triage level 2, or if you're using a different system, an appropriately high triage level and rapid placement. We're going to provide pain management according to the protocol that we're going to talk about next. So we start to assess their pain, treat their pain every 15 to 30 minutes. After 3 doses, and this is a modification of the guidelines, we reassess their pain for improvement. And if their pain is not if that is not improving, then at that time you may decide to admit to the hospital. If it is improving, then you want to continue to treat their pain aggressively, or transferred to observation and still continued to treat their pain aggressively, even in an observation unit or an observation status. So this algorithm is kind of the overall, which isn't a lot of detail, and we're going to go into a little bit more detail now into some of the pieces of this. So the first thing that we have decided is that they need to be a level 2. And they actually meet 2 level 2 criteria for ESI. Patients with sickle cell are high risk for many other reasons than vaso-occlusive episode. Oftentimes patients have, one of the bad complications, the number 1 complication that causes death is acute chest syndrome. They also suffer from sepsis or stroke. So these are not uncommon reasons that patients may be in the emergency department. And at triage, you can't always figure all of that out. So they're really at high risk for other reasons than vaso-occlusive crisis. The second reason that they meet high-risk criteria is that it is really severe pain. Patients have described this as, "Oh, my bones are breaking," and so it's really, really bad pain that you really cannot treat in a waiting room. They need opioids, they need to be monitored, they need to be assessed. So I always think of these patients as really bad kidney stone patients, because I wouldn't want to leave kidney stone patients who are on the floor because their pain is so bad in the waiting room. And this is the same kind of a thing. This pain is really severe, it's really debilitating. We can think of this pain as ischemia because it is, so it's ischemic pain that really does need to be treated right away. And we also know that rapid treatment, aggressive treatment, leads to faster resolution of pain, less need for hospital admission. So there are many reasons to really try to jump on patients, get rapid aggressive pain. Our goal for everyone is to be able to treat their pain so they can go home. And the longer we don't treat their pain, the longer they'll be there, etc. And in most emergency departments, sickle cell is not like chest pain in a very important way, and that is volume. There are many, many patients that come into the emergency department with chest pain, and we have evidence that we absolutely need to get their EKG within 10 minutes, and that is a burden. And yet we have figured out ways to be able to do that in emergency departments. The good news around sickle cell is most places, most emergency departments don't have more than maybe 2 to 5 visits a day for patients with sickle cell. So it isn't like having to find and treat 20, 25 patients with chest pain a day and get an EKG. It's really only a couple patients a day that we need to figure out how to get them a place and get them evaluated quickly. We also want to assess at triage for other, even if it is a VOC, these are other red flags. And in which case, if they have any of these other signs and symptoms, they're a higher priority than a straight vaso-occlusive episode. A VOC by itself is a high priority and needs to be managed right away. But if there is evidence of other kind of compromise, we really do need to jump on it. These patients could be at risk for sepsis, for acute chest syndrome, because not all pain also is VOE. So we want to make sure, is this new? We want to ask these questions. Is this like your typical VOE? If not, is it a new location? Is this more generalized? Do they have shortness of breath? Do they have any neuro symptoms? Any of these associated complaints are really serious. Any kind of fever in sickle cell is very high risk because they are very, very high risk for sepsis. They don't have their spleens anymore. And we can't look for fevers of 103 or 104 before we get worried in a sickle cell patient. These are the vital signs we need to be worried about. So we want to assess the intensity, we want to assess the location, duration, all the things that we normally do, but in particular asking these questions. Is this like your typical crises? If not, how is it different? How do you manage it? What is your individual pain plan? What works for you? Because we want to be able to treat patients with what works for them so that we can treat them quicker and more efficiently. And we definitely want to know what they take at home. Many patients, over 50% of patients with sickle cell also have chronic pain, and many take opioids. So we do want to know what they took and when they took it last. And if it's a pediatric patient, we want to use pediatric scales, etc. while they have much less vaso-occlusive episodes, they still can present with vaso-occlusive episodes as well. So once we've started treating their pain, we're going to keep treating them, evaluating them every 15 to 30 minutes, and re-administering doses of opioids and reassessing them for pain improvement. If it's resolved, again, they can go home. If it's not, then we want to, they can go home with good referral. If it's not, if it's improving, we really have the opportunity to continue rapid aggressive treatment, maybe in an observation status, etc., to avoid hospital admission. To think that every patient will have 3 doses and their pain will be resolved and they should go in or out is kind of old thinking. Patients often take more than 3 doses, or they take a little bit longer than an hour and a half. So if we give them a little time, in the outpatient day hospital settings, most patients are just aggressively treated for about 4, 6, up to maybe 8 hours, and they usually go home. The back of the algorithm here, we've kind of gone through, but we're going to go through it right now. These are the specifics that we're going to talk about right now. So we've talked about other sources, and we do want to treat it very aggressively, so we don't want to delay. One of the recommendations is a door to first dose of 60 minutes from registration. And this is actually better than the previous recommendations, where the recommendation was door to first dose of 30 minutes. Another recommendation is to use IV opioids, morphine or Dilaudid. Intravenous, because most patients have already taken oral opioids at home. If they wanted to take them, they already have them. So they have taken them, they're not working, and they need intravenous. And this is another recommendation. And in pediatric patients, it may be possible to start with Tylenol or with NSAIDs. Another recommendation from the guidelines is to use the sub-Q dose if obtaining IV access is going to delay the first dose or when it's not possible. And so many of you know that many patients with sickle cell have had so much pain medication over so many years that IV access is difficult. And oftentimes it takes multiple sticks to be able to find a place and to start an IV. And that in itself is a big barrier and leads to delays in the administration of that first dose. Not all emergency departments use subcutaneous route, and so we may not be used to it. It's used a lot in cancer, and it's pretty much the same. So the dosing is the same. And so you can give a sub-Q dose while you're waiting to to start your IV. We are used to giving IM, and we really shouldn't be doing that in particular in these patients because of the tissue damage and the erratic absorption. Over the course of the years, they've had many injections and has created a lot of tissue damage, and that results in really unpredictable absorption. So sub-Q is much better. It's a much safer route. Another recommendation is the use of individualized dosing plans that we alluded to before. I'm going to talk a little bit about that in a minute. The recommendations are also for if your patients don't have individualized doses because you don't have a hematologist that has written them for you. The recommendations recommend a standard sickle cell protocol. And we've done some work with a weight-based protocol to make it standard that I'm going to talk about. And another recommendation is to let patients continue to take their long-acting opioids if prescribed as an outpatient. Because when you think about it, again, the goal is to send them home, and they'd be going home on their oral medications. This is a website that you can actually access the algorithm, and this will pop up again in a little bit. So I'm going to talk for a minute about the data to support individualized versus weight-based protocols. And we actually just had this paper published in the American Journal of Hematology, and the reference is here. This was a randomized controlled trial basically comparing individualized dosing to a weight-based protocol for sickle cell patients. And our primary outcome was a change in pain score from arrival to discharge and compared between the groups. And we also looked at the other questions about the pain experience, whether they were admitted to the hospital, side effects, and safety. So this was an RCT in 2 busy emergency departments, not in North Carolina, only adults, and they could have up to 5 ED visits. We pre-enrolled patients in the clinic setting for possible future visits in the emergency department, and they were randomized after they were consented to get either an individualized or a weight-based dose, but all in adherence to the guidelines. And then the protocol was uploaded into the electronic medical record, and at the next ED visit, if they had one, that protocol was followed. Patients were then interviewed every 30 minutes by research staff prospectively, and pain scores were obtained as well as other side effect and safety data. So we talked about the primary outcome, change in pain score, and that was defined as discharge was when they decided to admit to the hospital, they went home, or 6 hours later. And then we did look at vital signs and patient satisfaction, side effects, etc. And what we found was that actually the patients in the, this is the pain change, so you want a higher number. And so really the patients who were randomized to that individualized dosing protocol had about a 16 millimeter difference, greater difference in reduction in pain score compared to the weight-based patients. And so that's really statistically significant. And this was for a total of 126 visits, and it was a total of 52 different patients. It's a little bit hard to see, but what you can also tell here between the individual and the weight-based protocols, you can look at the percent that had at least a 13 millimeter reduction in pain, which is important, was their so the patient's goal was met about a third of the time versus a quarter of the time, need for more pain medication, etc. And there really were no differences in any of this between the protocols, except for hospital admission. And so what you can tell here is that patients in the individualized dosing protocol were admitted less frequently, about 18% less of the time, 40 versus 58%. And that's really, really, really important. So the takeaway from this study was that patients involved randomized in an individualized dose versus a weight-based had greater reductions in pain scores and were admitted to the hospital less. Limitations are that this was a two ED study with 52 patients, and so we're trying to do a bigger study now. We're waiting to hear about funding. Side effects also are really important, and so nausea and vomiting was actually more prevalent in the weight-based group. Other than that, there were actually no differences. No patient needed naloxone, no patient needed intubation. There certainly was oxygen that was administered, but oxygen was all that was needed, and it was no difference between protocols as well. Because these were higher doses, especially in the individualized dose, but there really were no negative side effects. And I think that this is really important data as well, that we were able to administer opioid protocols, some were very high doses, really without any kind of negative side effects. And there's other data as well that support the use of individualized vaso-occlusive episode data or protocols. At CHOP from 2002 to 2008, Dr. Krishnamurti published a paper, and they implemented individualized protocols at CHOP during these years, and then they compared their data to hospitalization rates, and they compared data on hospitalization rates and readmission within a week for 4 local hospitals, and also looked at satisfaction with the protocol. So what they found was a greater reduction or a greater decline in the rate of admission for patients presenting at CHOP over the years. So they started at 78% admission and went to 52%. And when they compared it to the local 4 hospitals, their change in admission only went from 71 to 68%, and that was significant. And the same kind of trend in hospital readmission. So at CHOP over the years, readmission went from 7.3 to 3.2%, and in all the other hospitals, it just went from 6.5 to 5.1. They also looked at improvement in pain scores during management. ED management was 2 or more, and that was significant, I think, before and after. Participants on average really rated good quality of pain management as very good or higher on that protocol. And in another pediatric emergency department, Dr. Kavanaugh in Boston published this paper, and this was a QI initiative in a pediatric ED for the treatment of VOE. This protocol included a time-specific protocol, and they used intranasal fentanyl as the first pain medication, as a way to be able to get pain medication on board for these children quicker. And they gave a pain medication calculator, and they did some patient-provider family education. And they were able to see significant improvement in the ability to deliver the first opioid as far as time. With this protocol, they went from 56 to 23 minutes. The second opioid dose, they even were able to decrease that from 106 to 83. And the time for admission to discharge decisions went from 163 to 109 minutes. That was for admission, and then discharge decisions, you can see there as well, and initiation of PCA. And they actually, the proportion of patients discharged from the ED increased, so they sent more patients home instead of about a third, almost a half. They've also tried this protocol with adults, and the adults don't like the intranasal fentanyl, but it did work really well. Intranasal fentanyl worked really, really well in children and was very effective in being able to deliver their first dose of opioid according to the protocol much quicker. And the goal is 60, and they were able to do it in 23 minutes. So that's a little bit of data to support the individualized dosing. Weight-based dosing, oftentimes we're not familiar with the conversion, and so this kind of gives you a conversion of PO to IV. So it's a 3 to 1 for morphine and a 4 to 1 to go from PO dilaudid to IV. So it'd be, the IV dose is, the PO dose is 3 times higher than the IV dose. So to go down here, this is kind of the weight-based, and so this is some guidelines on weight-based dosing for morphine, for hydromorphone or dilaudid. What an IV dose, so you can see the PO dose is 3 times higher than the IV dose, and the PO dose of dilaudid is 4 times higher. And this is kind of a weight range of what the dose would be then. So I think this is, and this chart is also available on the website that I'm going to show you as well. And this is a dose escalation chart because the guidelines also recommend that you increase the dose by 25%. You consider increasing the dose if the first dose doesn't work. And if you wanted to do this, this kind of is a guideline as to what those dose escalations could be. And finally, with respect to the guidelines, there are also recommendations about adjunct agents. And the guidelines recommend administering oral or parenteral NSAIDs as an adjunct analgesic as long as there's no complications. And this is important because many patients with sickle cell do have renal failure and many have asthma. So before thinking of, as right now we think of opioid as a dangerous drug, for many patients with sickle cell, NSAIDs are a dangerous drug due to this high incidence of renal failure and asthma. And yet for many patients they also work, and we want to use them whenever possible. Hydration is really important, so we want to give IV or PO hydration. And again, many patients have other complications. There are many patients with renal and heart failure. So before giving them tons and tons and tons of fluid, we want to really understand what is their status with heart failure or renal failure. But adequate hydration is a really critical, important component of treating pain. We also used to just reflexively give oxygen to everyone, and the guidelines now recommend it really is only indicated if their SATs are less than 95% on room air. Another recommendation that was really important is around oral antihistamines. There are some patients that need IV Benadryl, and there are other patients who don't. But unless it's really well documented that patient needs IV versus oral, antihistamines should be PO. They are very sedating, and in combination with opioids can make someone very, very sleepy. And so that really is the logic that I use with patients, is that certainly if they're having a lot of itching and they need it, and I try to give oral. And if there is a reason that's documented they have to have IV, we'll give IV. But only the one dose. They don't need it repeated, first of all. And I use the rationale that I really want to treat your pain. When I'm giving you a lot of Benadryl, it makes you sleepy, and then you're sedate, and then it's not safe, and I can't give you more opioid when I would want to, and that's really what I want to do. I really want to get a good handle on your pain. And then finally, non-pharmacologic. So non-pharm, such as heat and distraction, are also recommended whenever available. And so we tend to see people who are maybe playing on their phone or trying to distract themselves and think that they're just not in pain. And in reality, they're actually doing something very good. They're distracting themselves. In patients with other kind of conditions, like cancer, et cetera, some hospitals have distraction carts that go around. It's the same thing. And because so many patients with sickle cell also have chronic pain, they really may be more aware of the need to use distraction, and they may be trying to distract themselves while they're in the ER. And then finally, back to hydration in pediatrics. Here's some recommendations for pediatric hydration. We're going to move now and talk about reassessment of pain. So we've done a great pain assessment, figured out what dose they need, individual or weight-based or whatever, and now reassessment. The recommendation is to reassess these patients every 15 to 30 minutes and to use some validated kind of sedation score, such as a RASS. We would not be recommending just treat without reassessing. Some patients may have high doses. And sedation is really the early indicator, even before pulse ox. So we want to reassess, and if everything is okay, we want to redose every 15 to 30. And the guideline says until pain is relieved, or pain relief is obtained. You'll notice in the algorithm we say after 3 doses you can reassess. And that's fine to reassess after 3 doses, but we still want to keep treating aggressively until their pain is relieved while it's safe and while their sedation is okay, until we know that we're not making any headway at all. But to think that every patient and the algorithm, because the algorithm says reassess in after 3 doses, it's really based on, okay, they might be great, maybe they need some more time and they need that observation unit status, but it doesn't mean 1, 2, 3, you're in or you're out. So we want to keep aggressively treating their pain. The guidelines also recommend considering escalation by 25% if there's no improvement in the pain score. So if they're really not getting anywhere with the first dose or the second dose, you may need to increase the dose. And then we've talked about this reassessing after 3 doses, but then continuing to reassess in at least every hour. If the facility if the ED uses PCAs, you probably want to be able to start a PCA after the 2nd or 3rd dose and make sure the patient knows how to use it, and make sure that you're still reassessing that patient, because perhaps even if they're on a PCA, the PCA dose may need to be adjusted. You can't just put someone on a PCA, assume the dose is right, leave them alone for 3 hours, come back later and say, how's it going? But the PCA is really important and should be considered if you can, recognizing that many EDs do not use PCAs. And then finally, consider transferring to an OBS unit if that's an option, because many patients that are treated aggressively in the outpatient setting for their pain are discharged home. So that's the algorithm. What we're going to talk and end with now are some more resources and thinking about back to some of those patients with high utilization, but really beyond that. So what we have what's another box on the back of the algorithm card is discharge home, some information about prescriptions and referrals. So you want to be able to consult case management or social work early to identify unmet needs. And I'm going to show you a screening form and some data that we have been able to obtain by using that screening form. And this project actually started with the high user because there were high users and we wanted to understand them. And we kind of understood that they do have a lot, we learned they have a lot of unmet social behavioral health needs. We wanted to be able to refer them to have those needs met on an outpatient side because the ED can't really fix that. We also want to encourage patients to get their prescriptions from one sickle cell provider. This is really important. Emergency department providers should not be writing opioids unless there's some really, really, really good reason to do it. If they're not available, then you can do a short course, but that's it. You also want to check the prescription drug monitoring program. And in light of this opioid crisis, there's a risk of not treating acute pain. We need rapid aggressive treatment of acute pain, and we need very judicious not prescribing opioids. So opioid prescription for this population is not recommended at all. They should be getting those drugs from their sickle cell provider. And encourage the patient to follow up with their PCP or sickle cell provider within several days. And referring patients back to the Community Care North Carolina call center for care management follow-up. And the screening form that I'm going to talk about gets faxed to them to one number, and I'm going to talk about this program now. If you're viewing this presentation from another site, the needs are probably still there. The resources may be within your hospitalist, case management, or social worker, or some other set of resources that you may need to explore and figure out what are the resources. Because when there are patients in the emergency department, several times a week, it is frustrating and they don't go away by themselves. So that is one of the big barriers, is the frequent visits. And we really wanted to understand that a little better and do something about it. One of the things on our website, the Sickle Emergency website, is another video on the high user that I think, again, is very well done and addresses and role models some of the behaviors. So we have done some work in this area, and this was a project with 3 emergency departments back in Illinois, and I just kind of wanted to highlight this finding where we had patients, and I believe this was over a period of, I think, about a year and a half or 2, and what you can see that should immediately stand out to you is that there was one site with very few sickle cell patients and a whole lot of visits, and over the time period. They had almost as many visits as the other 2 urban academic sites with a huge, much bigger number of sickle cell patients. And what we learned from this is that some of these 31 patients were, first of all, really, really, really sick. And second, there was not a single physician or provider, nurse practitioner, anyone in this hospital system that would see a sickle cell patient on the outpatient side. So literally the only place that these sickle cell patients had to get care was in the emergency department. And they were sick, so they were there a lot. And legitimately so, because there wasn't a provider. Now, because of this data and because of this study, that's not the case there at all anymore. They have providers and they have a system of care, but they didn't, and this is not uncommon. This is some national data from HCUP. This is very recent data that I think was published in 2017, but it was 2014 data. And this is looking at admission and readmission to the hospital. And among Medicaid patients only, so just Medicaid, sickle cell anemia ranked as the #1 most common principal diagnosis for readmission within 30 days, and then second within 7 days. And the #1 cause of readmission is admission. And the #1 reason for admission is painful episodes. So the more that we're able to do rapid aggressive pain control in the ED and avoid hospital admission, the better off everybody is. So we're going to end on the social behavioral health needs. And this is some data that we were able to get out of our emergency department here at Duke. And actually at right, these are just our Duke patients. And we implemented a screening, a very simple screening form that I'm going to show you that the social workers actually did in the ED. And this was over about a year and a half, I think. We had 147 ED visits in which the screen was administered. And as you can see, there was a high prevalence of anxiety, depression, a fair number of transportation issues, pharmacy issues, insurance challenges. These are all things that care managers can assist with. The process in North Carolina that we're very, very fortunate with is to partner with Community Care North Carolina. CCNC, for Medicaid patients, every patient in North Carolina has a care manager, and they can assist with all those needs for Medicaid patients. So we implemented the screen that you can actually get at this website, but we implemented the screen that anyone in the emergency department can fill out the screen, fax it to one number at CCNC. They determine who that person's care manager is, and if they're not a Medicaid patient, they refer it to the state sickle cell syndrome program. They have educator counselors, and now those patients are followed up with the educator counselors. So the screen can be done by anyone, basically a nurse, a physician, a social worker. You fax it to one place and they take it from there. And this is the case management referral form. A little hard to see this, but this is the form, and it basically has a data referral, the patient name, date of birth, Medicaid number, the referring ED, referring provider. The patient is aware, so we ask, it's okay, we're gonna whether or not they know. So if they have a primary care provider, we ask them to put in that name. If they have a sickle cell doctor, ask that. Excuse me. And then finally, these are the needs. So this is a streamlined list of needs that you can screen for, and it's emotional, financial, medical, prescriptions, family, transportation, pain management. And then you just fax it off to this call number. So part of the dissemination project, what we're asking for is that that emergency departments adopt the Vaso Occlusive crisis algorithm, and that they also start to be able to use this form to refer patients back to CCNC. This is the fax number, gets faxed to their care manager, etc. And to date, there have been over 800 referrals made back to CCNC. And what we have been able to track is the status of care management. So the numbers are really quite impressive in the number of patients that have now been identified out of emergency departments that were originally not receiving care management services. They were just sort of off the grid, that now are in active follow-up for care management CCNC. And finally, just a word about prescriptions. I think we've kind of covered this already, but their PCP or their sickle cell doctor should be writing them. If they're not available, you can do the short course, etc. So back to the pretest questions before we finish here. The right answer to this is all of the above, because we do want to know. We want to scale, we want to know how this compares to their past pain episodes, and we definitely want to know what medication they take to resolve their pain crisis. The correct answer here would be morphine 10 IV. We certainly don't want to give intramuscular. Patients need an opioid, and 1 milligram of Dilaudid would not be the right dose for this patient, but 10 milligrams is a weight-based dose for this patient. And finally, the last patient here should obviously be screened and referred to Community Care North Carolina. They should not be told not to go back to the emergency department. And these are the rationale for the answers. So kind of in summary here, we have this patient, and we are always trying to do the best. Emergency nurses and doctors really care about our patients. We're hopeful that this presentation actually will provide you with resources to be able to feel more comfortable to take care of patients, and we are always available to help with that. So hopefully the referral form and the algorithm are going to be good resources for you, and the toolbox, etc., will be helpful for you as well. So in closing, these are some of the websites that I referred to earlier. SickleEmergency.duke.edu has many short PowerPoint presentations, unlike this one. It's 10 slides with videos in them. There are also video recordings just as standalone on this, so many, many educational resources for emergency providers. SickleAware.nursing.edu is where you'll actually find this presentation, as well as more information about both the research grants that are ongoing. And then finally, the App Store. If you go to the App Store and look for SCD Toolbox, the algorithm will be on the will be part of that toolbox, as well as other algorithms as well. So in closing, I hope this has been a helpful presentation, a big broad overview of the recommendations, and I hope that you have lots of success in implementing evidence-based care for sickle cell patients in your emergency department, and see all of this as resources for you to be able to provide better care. And of course, we're always available here at Duke and the School of Nursing and School of Medicine for any other kind of additional help that you may need. And here are our websites, so please feel free to contact us at any time, and thanks again for all of your participation, and good luck.